Well, I'm Dr. Katie Smith. I'm a child and adolescent psychiatrist. Thank you, Dr. Judice, for the introduction. So I have two topics that we're going to be talking about today. And our first lecture is going to be about depression in children and adolescents. I don't have any financial disclosures. Our objectives for today. We're going to use the diagnostic criteria for major depressive disorder to be able to identify when a patient is suffering from major depressive disorder, to effectively be able to treat depression with appropriate medication and to familiarize ourselves with appropriate dosing and augmentation strategies. And then also we're going to identify at-risk behaviors and signs of suicidality. Do y'all see a lot of depressed kids in outpatient? Yeah. So briefly to go over the criteria. Criteria for major depressive disorder are going to be 5 or more of the below symptoms lasting at least 2 weeks or more, representing a change from previous baseline functioning. And so we'll see, not only depressed mood, but also anhedonia, loss of interest or pleasure, change in appetite or weight, change in sleep, psychomotor agitation or retardation, low energy, feelings of guilt or worthlessness, focus issues, and at times recurrent thoughts of death and suicide. Major depressive disorder causes impairment in social, occupational, or other, academic or other areas of functioning. And then we also have persistent depressive disorder, formerly known as dysthymia. And so this is depressed mood most of the time for a year period. In adults, the criteria requires 2 years. And the symptoms include 2 or more of some of the same things: appetite change, sleep difficulty, low energy, low self-esteem, poor focus, feelings of hopelessness. I see several teenagers, who report like chronic, long history of depression, who meet the criteria for dysthymia, and then they can end up having also a major depressive episode on top of this, and we tend to call this double depression. So depressive disorders, what we see in kids, a lot of similarities with depression in adults, but there are some differences that can be attributed to the child's developmental stage. Young children, pre-adolescents, we see a lot of irritability in their depression, poor frustration tolerance, tantrums, a lot of somatic complaints, headaches, stomach ache, I can't go to school, I don't feel good. Younger children, hallucinations, psychosis actually is a little bit more common. Social withdrawal. And kids, young kids are not always able to verbalize their feelings of depression. They just know something's not right, I'm not feeling good. And so it can require a little bit of detective work sometimes. Adolescents, typically if they get depressed, they're going to have more melancholic symptoms. They're very dysphoric, very sad, crying a lot. When we see depression with psychotic features, often that is associated with a fairly strong family history of bipolar disorder or psychotic depression. That's obviously a more severe depression, greater long-term morbidity, and increases the risk down the road of bipolar disorder. So in children, pre-adolescents, major depressive disorder is very rare. About 2% of kids, male to female ratios is equal. In teenagers and adolescents, the rate is up to 8%, a little more common, or twice as common in females. By adulthood, by age 18, there is a 20% cumulative prevalence of major depressive disorder. Data on dysthymia or persistent depressive disorder, kind of similar rates, almost 2% in children and anywhere from 2 to 8% in adolescents. Now, most kids with depressive disorders are going to have comorbidities, anxiety disorders, particularly, followed by disruptive disorders, which we'll talk about this afternoon, ADHD, and substance use disorders. A lot of older, kids, they try to self-medicate their depression. They may turn to alcohol, marijuana, or other things. Anxiety disorders, really, that's the biggest comorbidity. And sometimes, sometimes the depression can come first and sometimes the anxiety comes first. We think about maybe someone with social anxiety disorder. I think that the data is about 70% of them have major depressive disorder, but really, it's pretty much all of them from what I see. Anxiety disorders can be very impairing and very distressing. So the clinical course of major depressive disorder, if it's untreated, generally about 8 months. So that is a very long time. It's a whole school year. Most cases of major depressive disorder resolve, but the probability of recurrence is 20 to 60% within a year or two, and then within 5 years can be 70% of them are going to have another depressive episode. Prepubertal childhood depression, about 20 to 40% of them are going to develop bipolar disorder. In a 2006 study, 8% of high school students reported attempting suicide within the past year. So that was actually, I was shocked. I'm a child psychiatrist. I was very surprised when I saw that number. It definitely happens. What are some risk factors for suicide or suicide attempts? The number one risk factor is a history of prior attempt. Anytime a kid is having those kind of thoughts, we definitely want to ask them, have you ever done anything? Doesn't matter how long ago. Other comorbid psychiatric disorders, substance abuse is a huge risk factor because their thinking is impaired if they're intoxicated. Other risk factors include impulsivity and aggression, availability of lethal agents. We always want to have that talk with families about locking up the weapons, removing the weapons from the house. We have, in Louisiana, we have a lot of hunters, a lot of, outdoorsy people, and some of them are very adamant about not wanting to remove their weapons. We counsel them the best we can. They lock them up. They think their kid can't get to them. All we do is just, recommend they remove the weapons. And also medication. If, overdose is something, particular that girls may do as a suicidal gesture or attempt. If we have that concern, or if someone's being discharged from the hospital, we want to recommend that they lock up a lot of the medications. Other risk factors for suicide would be exposure to negative events. And, in our teenagers, we see, breakups, bullying, fights with family. A lot of times there may be a negative event that triggers these suicidal thoughts. Any family history of suicidal behavior or suicides is a big risk factor. And those who have attempted suicide before, the rate of reattempting is up to 15% a year, with the highest risk occurring within 3 months of that first attempt. In a suicidal patient, if someone's actively suicidal, the most appropriate step is going to be to hospitalize them. And, I'm sure y'all have these conversations with patients and parents in your office, and they're worried, they don't want to go. Oh, I'll watch her round the clock. But and I tell parents, you try to watch her around the clock, but what if you have to go to the bathroom? What if you fall asleep? I've had parents say, I literally had to wrestle the pill bottle from her hand, but I still just want to take her home. But in the hospital, hospitalization provides intense supervision, no access, of course, to weapons, pills, things like that. One-on-one observation, 24 hours around the clock if necessary. And in addition, the therapeutic programming, several hours a day of therapeutic activities, and involvement of the family in some counseling sessions. So what are some of the treatments of depressive disorders? Of course, it's we think medicine versus therapy, and kind of where do we go? What do we choose? Now, in a minor, mild to moderate depression, the choice of treatment, is really going to depend on maybe family preference, availability of therapy, availability of the family to go to therapy. I see in outpatient, sometimes, families come in, they're horrified by the thought of medicine. Okay, that's understandable. But then I also see families who come in who are horrified by the thought of going to therapy. They're like, can we just have a pill? And so I think it's important to try to kind of feel out what they're wanting, what their goals are. Psychoeducation and supportive therapy are going to be an important part of each phase of treatment. And also focusing on strengthening the relationship between the child and the parents or caregivers to reduce family dysfunction and facilitate treatment referral for other family members if needed. A lot of times the kid may be the identified patient, he's the problem. I'm not, mom and dad, we're not contributing to his depression at all, but there could be some real family conflict. And so sometimes referral maybe for some family therapy, individual therapy for the parents. I see you're very stressed by this, maybe you should see someone as well. And sometimes therapy for the parents can make a really big difference in the household. So the main types of therapy for depression would be CBT, cognitive behavioral therapy, and interpersonal therapy. CBT involves, how our thoughts contribute to our emotions and our behaviors, and so we work on changing our negative thoughts to positive thoughts. That can help change your behaviors, change your emotions. Interpersonal therapy focuses on personal relationships, whether it's family relationships, dating, romantic relationships, friendships, and family therapy, of course, can also be beneficial. Now, when using medications, it's very important to involve the family to talk about the symptoms, to assure that the child is safe and is taking the medicine, and also to monitor treatment progress. So we'll go a little bit into specific medications. So the first mainstay of treatment of depression is going to be our SSRIs. All the SSRIs have positive studies. Others, SNRIs, mirtazapine or Remeron, maybe have equivocal studies. In young people, there's a high placebo response, and children. They have a bit of like magical thinking, and so they take one dose of Prozac or something, and they're like, oh my gosh, I've never felt this good. They have a high placebo response, so that can affect some studies for sure. The remission rate for major depressive disorders for first treatment is only 30 to 40%. The response rate, 50% reduction in symptoms is higher. As far as FDA approvals for antidepressants, escitalopram, which is Lexapro, is FDA approved age 12 and up for major depressive disorder, and then fluoxetine, which is Prozac, is FDA approved age 8 and up. But actually, sertraline or Zoloft is approved at age 6, but that is for OCD. But it is something we still use a good bit. And fluvoxamine, trade name Luvox, is also FDA approved in young people for OCD. So as far as individual medicines, fluoxetine, FDA approved down to age 8. It may be something I use in depressed kids who have just real low energy, can't get going in the morning. It can be a little bit energizing, activating. It has a very long half-life of about 5 weeks. And so if you have a patient who maybe is not very reliable, or they go to dad's on the weekend, they miss it, they don't always take their doses, Prozac could be something to think about because of that long half-life. Zoloft or sertraline is FDA approved at age 6 for OCD. It not only affects reuptake of serotonin, but also affects dopamine, and so it can help a little more with motivation and concentration. Citalopram and escitalopram, FDA approved age 12. These are considered to be a little bit cleaner, the cleanest of the SSRIs. They don't have a lot of side effects or interacting with anything else. The citalopram may prolong the QTC, and Lexapro can as well. Lexapro is the active enantiomer of Celexa. Has no P450 inhibition, so if we're worried about drug interactions, definitely escitalopram is the way to go. And also people maybe who are sensitive to side effects, very sensitive to medicine, escitalopram is something that I tend to go to. Paxil or paroxetine. I listed it, because it's an SSRI. It's not really one that I tend to use. Some people may come in on it. It's a lot of side effects, very sedating, anticholinergic side effects. There's no FDA approval in kids. And back when we were using the pregnancy categories, it was category D. So it's probably not the best first choice. Some people with PTSD, they can really benefit from this medicine. It's can be very sedating. We give it in the evening, can be very calming. And it actually has a very short half-life, and when withdrawal, if you miss a dose, can be pretty uncomfortable. And then the last SSRI is fluvoxamine. That's FDA approved for OCD, and it's I mentioned it because it is an SSRI. There's no FDA approval for major depressive disorder in kids or adults, but it can be used. Something that I'm sure y'all see from time to time. SNRIs, the selective serotonin and norepinephrine reuptake inhibitors. So those are going to be your venlafaxine, desvenlafaxine, and duloxetine. So these inhibit both reuptake of serotonin and norepinephrine, which in turn boosts dopamine. And in adults, the SNRIs can do really well, can be more effective at times than the SSRIs. Studies in kids are kind of equivocal. Cymbalta, duloxetine, is FDA approved at age 7 for anxiety, generalized anxiety disorder. There's no approval or indication for depression. And now, that being said, I definitely have kids that I have on some of these medicines, and they do well. Other antidepressants, we have bupropion, Wellbutrin, which is considered a reuptake inhibitor of dopamine and norepinephrine. This may be something I use in people who, rather than being, sad and melancholic, they're just like, I just feel blah. I don't have any joy. Nothing's fun, low energy, things like that. And it can be a very effective medicine. It can be a little activating. In those with insomnia or anxiety, it can worsen those things, but I've also seen it improve anxiety. Wellbutrin is considered a third-line treatment for ADHD. There is some data, especially in older people or adults, that it can help with focus, alertness. We do have to be aware that bupropion can lower the seizure threshold, typically in doses of 400 or greater, which is a pretty high dose of Wellbutrin. So in those with already having seizures, head injuries, those with eating disorders and electrolyte imbalances, it may not be, it would be something we have to really consider before prescribing bupropion. Remeron or mirtazapine is an alpha-2 antagonist. And so instead of affecting the reuptake of serotonin, it actually potentiates serotonin release. It can be a good medicine to combine with SSRIs at times because it has a very different mechanism of action. It can be, has some pretty significant side effects. It increases appetite. Some people can really gain some weight, and it can be very sedating. But these side effects are things that at times we really want to use to our benefit. I mean, because a part of depression can be, very low appetite, weight loss, and sleep difficulty. So I've had, some kids that put on Remeron, and of course, they all tell me, I don't sleep any. And some of them we put on the Remeron, mirtazapine. It really helps. They rest better. They feel better. And other people, that first dose, it's too strong for them. They take one dose and they sleep for 12 hours. But it does have its place, and it can be very good medicine. Now, buspirone is really an adjunctive treatment. It works. It's an anxiety medication. It's a 5-HT1A partial agonist, and it can be used to augment depression or anxiety. And I also use buspirone in if y'all have kids with bipolar disorder. Who also have some anxiety, a little touch of Buspar can make a big difference without, having to worry about throwing them into mania. Antipsychotics, y'all see people maybe on some antipsychotics at times, and they came aripiprazole and quetiapine are FDA approved in adults for augmentation of antidepressants. They also would be something that we would use maybe in a psychotic depression, if a kid starts to hear voices or has some delusions or paranoia. They are not FDA approved for anyone less than 18 for depression, but we do know, we have some safety data because Abilify has been used down to age 6 for autism spectrum disorder for aggression, bipolar disorder age 10 and up, and schizophrenia age 13 and up. Quetiapine also is FDA approved age 10 and up for bipolar disorder, and then schizophrenia age 13. Seroquel definitely is very sedating. Can cause weight gain, increased appetite. Abilify, about 30% of people have increased appetite and weight gain. But the rest of them, it's pretty weight neutral. It can be sedating in some people and non-sedating in others. But it can be a very good augmentation strategy at times. So any medication that we choose to start, we want to start with low doses. Kids do have higher metabolisms, younger kids, and so we may need to use twice daily dosing to avoid any withdrawal symptoms. In general, I use once daily. But that would be something with a short half-life if someone was on maybe paroxetine or a non-extended release Effexor or Wellbutrin. The goal of treatment of depression is remission by 12 weeks. We always want to monitor for suicidal ideations. The FDA recommends monitoring weekly for the first 4 weeks and then biweekly after that. It's hard to not only to have time in our schedule to see patients once a week, but also for them to come. And so this could be something, you educate the family on when you're starting an antidepressant. Make sure that the parents are talking to the kid. And then also maybe schedule a brief phone visit, just to check in and see how the kid is doing. Of course, there is a black box warning on all antidepressant medications issued in 2003 by the FDA. And this is not from any individual studies, but pooled data from several studies indicated that there was a 0.7% increase in new or spontaneously reported suicidal thoughts or suicidal behaviors. There was not any increase in suicide attempts or suicide completions. When the black box warning was published, it led to a 25% reduction in SSRI prescriptions that year, and then the suicide rate actually increased 14%. And so from this, we do know that antidepressants save lives, and they are. I guess the drug companies are trying to undergo or do new studies to show that this is not true and get the black box warning removed. But I think that's been going on for several years, and this black box warning is still there. Number needed to harm as far as suicidal thinking or behaviors is 112. And so we know with the increase in use of SSRIs, there's been a dramatic decline in adolescent suicide. We'll go through a couple of studies. Treatment of resistant depression, Tordia study. This was a study of 334 adolescents who had already failed one SSRI. They had at least 8 weeks of an adequate dose of SSRI. And so the study was, well, let's place them on a different either SSRI or SNRI. And then let's, also add in an arm of therapy. Either, they get or they don't get cognitive behavioral therapy. And so after 12 weeks of the medicine switch and then the therapy or no therapy, there actually was no difference. There was a response rate, of course, 40% response, but there's no difference in the medicines themselves. SSRI versus SNRI, they all seem to have pretty equal response. The combination of CBT plus medication was more effective, about 55% response rate versus 40. After a little bit longer, 24 weeks, they saw that those who had partial response in the first 6 weeks were more likely to remit their depression, 61% versus 18%. And then there was, after 24 weeks, there was a 20% relapse rate in major depressive disorder or episode. And the associated factors with a relapse rate tend to be the family conflict, maybe some substance use or a comorbid anxiety disorder. So really the take-home points from this study would be, if someone has a partial response in those first few weeks, then let's keep on that medicine, and maybe increase the dose, give it more time. If people have not responded within 6 weeks to a medication, not any response, it's time to switch. And then really, if you're starting your second antidepressant, if they've had treatment failure of the first one, you need to also refer them to therapy, counseling. The Texas Children's Medication Algorithm Project in 2007, a conference on physicians, researchers reviewing all the current data in 2007, and they came up with a treatment algorithm for treatment-resistant depression or for depression, and so their algorithm. Fairly similar. You start with an SSRI. If they fail that one, you try a second SSRI. If they fail both of those, then it's time to think about switching to a different class of medicine. And so that would be your bupropion, mirtazapine, venlafaxine, or duloxetine. Or another, if they've had some partial response with their SSRI, you can augment the SSRI with another, antidepressant or lithium. And then always treat any comorbidities which may contribute to the depression, which can include family issues, substance, and other diagnoses. And I know sometimes you'll have questions about kind of switching antidepressants, cross-tapering, and there's really no definitive guidelines. And what I do, if we're just doing one SSRI to another, I just kind of guesstimate, or I guess I know kind of what are some equivalent doses. And so maybe if we're on a 40 milligram of Prozac that really hasn't been effective, or they're having side effects, maybe we do a clean switch to 100 milligram of Zoloft. And generally that's very well tolerated. There shouldn't be any kind of withdrawal or side effects. Some people are more comfortable, doing a little bit of a cross taper, like maybe let's do half. Cut your first antidepressant in half, and then we'll do a half dose of the new one for a couple weeks, and then we'll make a full switch. If switching between classes of medicines, from SSRI to SNRI or to bupropion or something, a longer cross taper is beneficial. In general, if I'm going to do what I think we talk about later, getting patients off of medicine, but I'll do, if we're tapering off, I may do, like 25% dose reduction every 2 weeks, something like that. Tapering off antidepressants. Major depressive episode, the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry recommend treatment of depression for at least 6 to 12 months following remission. That's something that I always tell the family. And of course, am I going to take this forever? I say, well, no, but definitely we want you to take it for several months, and then when you feel when it's time to come off of it, that's something we want to do together. And then some people, after 6 months, 12 months, they don't want to stop, and that's okay too. If you're doing well on your medicine, there's, not necessarily any reason to stop. So, taper gradually over at least 6 weeks, if not longer, to avoid discontinuation symptoms and relapse or recurrence of depression. With kids and teenagers, we may want to think about tapering off during summertime because we don't want to do anything that would affect their schooling. Discontinuation. And so some people, like I said, I might do like a 4th dose, decrease every 2 weeks. Some people are just very sensitive to coming off of the medicines. And I mean, there's nothing wrong with taking a few months to do it, maybe instead of a 4th dose, we'll do an 8th dose. And maybe we do it for 3 or 4 weeks, they'll tell you, the patient or the family will tell you if they're having withdrawal side effects. And some of those, discontinuation symptoms would be difficulty sleeping, irritability, some GI symptoms. They'll have like palpitations or, they feel real anxious. There's also can be an electric shock-like sensation that some people feel. And I had a college student who, unfortunately he went through all of this and didn't tell me. I was like, I would have happily worked with you, walked you through all of this, but he just, he came back in, he was like, yeah, it wasn't pleasant. But we definitely can make it easy, just by going slowly. Another strategy for stopping or tapering off medication, since fluoxetine does have a long half-life of 5 weeks, if someone is having a really hard time getting off of their medicine, we may just go ahead and add a low-dose fluoxetine, like maybe 20 milligrams, slowly get them off of their first medicine, and then we taper off the fluoxetine. Maybe we do 10 milligrams for a few weeks and then stop, because that'll stay in their system, still be in their system for several weeks. And so that is a way that we can taper off of the antidepressants to minimize their, withdrawal effects. So relapse or recurrence of major depressive episode. So associated factors, of course, prior depressive episode, how many they've had. Women, females, prior suicidality, concurrent dysthymia, personality disorder or negative life events. These are things that would be associated with a recurrence of a depressive episode. And the general rule, I would say if they've had 3 episodes or more of major depressive disorder or hospitalization, suicide attempts, we may want to consider lifelong or at least several years treatment, just to help prevent further relapses. Each episode of major depression can potentially be worse than the previous, and then it can be harder to treat, the more episodes they've had. So some take-home points for today. Major depressive disorder affects up to 8% of adolescents, 2% of children. Suicide attempts do happen. I'm kind of, I deal with suicidal people every day, but I'm really an optimist. I just always think, things are going to be okay. We'll get through this. Things will get better. And I want to, instill that hope, to the parents and to the kids. But bad things do happen, and we really have to, do our best to identify those risk factors, those thoughts, and do what we can to, get the kid, the treatment that they need. Both medications and therapy can be effective. In more severe cases of depression, both medication and therapy is the best. And I think that's it. Questions? Thank you.